Hello again, this is Earl Silverman, Editor-in-Chief of the Journal of Rheumatology. Welcome you back as I highlight a paper of particular interest from the August 2023 edition of the Journal of Rheumatology. Today, I'll be speaking with Doctors George Greene, David Cella, and Eric Ruderman, who are three of the authors of their article entitled Integrating PROMIS Measures in a Treat-to-Target Approach to Standardize Patient-Centered Treatment of Rheumatoid Arthritis. And I want to thank you, three of you, for taking the time to speak to me and to our listeners on behalf of all the authors of your paper. So with that, we might as well begin. So the first question, could you please review your previous work that led to this study?
Well, Eric, how about you want to start?
Yeah, I can take some of that. I mean, in many ways, this was based not just on our previous work, but other previous work that had been done before us, and it really focused on the whole point of treat to target. From the very beginning, the concept of treat to target in rheumatoid arthritis was really about measuring outcomes and adjusting therapies to those outcomes to try to get the best result in the long run. And from the very beginning, the treat to target concept has stressed the idea of patient involvement. And from the very first papers that came out, that was really sort of not evidence-based, but a consensus on the approach to treat to target. It was recognized that patients should be involved, and there was actually a patient-focused paper that came out early on. But with that, most of the clinical trials that we had seen in general, and even some of the ones specifically focusing on a treat-to-target approach, really looked at composite clinical outcomes and not specifically patient-reported outcomes, the kind of things that patients care about, their disease impact, their thoughts about therapies, their concerns about cost of therapy, ability to work, those sorts of things didn't really enter into it. And so we set out to determine whether the whole idea of treating to target could be more individualized, that we could look not just at a sort of a global outcome of the standard clinical measures, but whether there were outcomes that were unique to individual patients that might really help us get them to where they needed to be, as opposed to where the generic patient with rheumatoid arthritis needed to be.
Would you like to add anything, David or George?
Yeah, I would like to add to that. I think that was a really great intro. About 3 years or 4 years into the treat to target publication that came out now over 10 years ago, George and I approached Eric and his practice about the idea that we could help contribute to bringing the patient voice into the targeting of treatment more explicitly by using our PROMIS computerized adaptive test, which we're very excited about and had developed with NIH funding in the prior decade. Eric was excited to try that, and so we launched an early pilot where we got the baseline data for this publication and published that baseline information showing some interesting things, some which would not surprise rheumatologists at all. We gave patients 5 choices to choose from as to what to target in their treatment approach from their own perspective. One was pain, one was physical function, another was fatigue, and then another depression and social function. And lo and behold, probably won't surprise anyone in this audience, the 2 main things selected were pain and physical function. However, fatigue was chosen in over 15% of patients as what they would really like to focus on, and even depression and social function got selected by 10% of patients together. So you don't always know what the target is unless you explicitly ask the patients, and we gave them these 5 options and then used that information to track that particular symptom that they identified as what they wanted to be their chosen target.
Thank you. Anything else, George?
No, I think Dave and Eric covered it really well.
Great. So, it really is the way people talk about individualizing treatment, not medicines, but patient treatment. And this is going beyond just individualizing patients' medicines. That's great. So with this knowledge, what were the aims? So that we've explained leading up to, what were the specific aims of the study?
Okay, I can take that. So just echoing what Dave and Eric mentioned, in our earlier work, the article that Dave was talking about, we demonstrated the feasibility of integrating patient-reported outcome measures in an RA clinic with limited disruptions to workflow. And consistent with other research, we also showed that PROMIS measures are valid and reliable measures to use to assess patient preferences in clinical care. So that's the foundation that we're working from. So in this follow-up study, we had two main goals. The first goal is that we wanted to evaluate any impact that a patient-centered treat-to-target approach to care using PROs would have on patient outcomes. And secondly, we wanted to evaluate patient satisfaction with this care approach that was more personalized. So I would say those are the two main things that we focus on for the current study in the journal this month.
Any other thing to be added? Good.
No, I think that gets it. We were just trying to bring more into the exam room for the clinicians who are seeing these patients than the usual things they were looking at, to try to identify how much that would help them, address their disease and make treatment decisions.
It sounded great. It's certainly a noble thing to do when we have the time. It's what we want.
Right.
Absolutely. So who did you study? What was the entry criteria? How many patients? You just outline a little bit of that.
Sure. For this technical part, I can take care of this as well. The participants in our longitudinal pilot study, they were recruited from an academic rheumatology clinic. We recruited a sample that was evenly divided into two groups. The first group included individuals who were in remission or who had low disease activity, and that's reflected in CDAI scores of less than 10. The second group had individuals who had moderate to high disease activity with CDAI scores of greater than or equal to 10. Individuals were included in the study if they were 18 years and older, if they had a physician-confirmed diagnosis of RA, and if we had CDAI scores available for them at the time of enrollment. And specific to the CDAI scores, if they were greater than or equal to 10, we needed clinician confirmation that the patient was an appropriate candidate for treatment acceleration. And also the patient had to be willing to accelerate therapy or escalate therapy if it was needed. So as a result of our recruitment efforts, we ended up with a sample of 119 participants. Their mean age was 57 years, 90% were female, 11% reported that their ethnicity was Hispanic, Latina, or Latino, and 70% reported that their race was white. So that was their sample for the study that we're reporting on.
Okay.
Which I think it's fairly representative both of RA in general and the types of patients in general that we see in our practice. That's kind of the spread of the patients that we get within our practice on a regular basis.
Well, it's important, obviously. We don't want selection bias coming in. So, and what did you measure? What were the variables, the outcome variables?
We've got a whole list of variables that I can go through these with you. Not too much detail, but just to give you a sense and save some for the readers to dig into the journal article.
Yeah.
So we measured RA disease activity using the CDAI. We measured functional status using the RAPID-3. Those were both collected in clinic. As I described earlier, we collected patient demographics. Those were collected online using an online survey platform called Assessment Center. We measured patient reports, as Dave mentioned, of fatigue, depression, pain interference, social function, and physical function. Those were PROMIS measures. Those were CAS, the computer adaptive tests. We had a couple of measures of patient satisfaction. One was an overall measure, a single item. And they also used the FACET TSPS, which includes 5 subscales of satisfaction. 3 of them focused on communication, another one focused on technical competence of the provider, and the last subscale for that was, I believe, confidence and trust that the participant or the patient had with their provider. So in addition to all that data that we collected from patients, we also surveyed clinicians, and we wanted to know whether or not they had made changes in their treatment at that time of assessment, and whether or not those decisions were based on PROMIS data.
I think just to add a little bit
Yeah.
there, if I may, and thank you, George, really great description. You can probably see that our goal here was to round out the usual clinical picture with a focus on not just how the patient's feeling and functioning, but also how they're communicating with their doctor and whether there's any evidence of shared decision-making going on that would then manifest itself in patient satisfaction with care, or review of whether they had a role in that treat to target activity and changes in direction or course of therapy as a result of what they're reporting. So to really see if we can get into that communication dyad.
Anything you want to add, Eric? Or?
No, I think that was it. And you know, one of the challenges as we went into this, and was an ongoing issue, was to try to do that in a way that it didn't extend the visit, you know, unnecessarily, because that, you know, on a regular basis in a practice, that's critical. If you're gonna, you can ask all the things you want, and if it's too complicated and it makes the visit too long, nobody's going to do it. And so we worked very hard to try to streamline this. It's, you know, as so many of these things are, it's a challenge because we had our electronic medical record, but we also had a separate system that we measured the PROMIS scores in, and trying to integrate that was a challenge, but we managed to do it in a way that I think made it a bit more seamless for the physicians, and we tried to provide them with that information when they went into the exam room with the patient, so they had all that at their fingertips at the time of the visit, rather than trying to, you know, do it during the visit and extend the visit link, which was just going to be impractical.
So if I'm understanding, the patient did that at the time, but prior to time of the visit, but prior to seeing the physician.
Yeah, we tried to do some of it online ahead of time in terms of the visit, and some of it in, you know, if we couldn't do that, we did some of it in the waiting room before they came in, basically, so that we could try to provide all that information in real time when the physician sat down with the patient.
Sure, that's great.
So,
And
I think it might be worth mentioning, particularly to Epic users in the audience, that this work was done 8 years ago when Epic did not have very good functionality with regard to what we needed to measure. So we had to create this outside system that Eric referred to there, capturing the information from patients outside of Epic. But now Epic does produce much more capability, including the PROMIS CATs, to do these assessments within the patient portal, the MyChart patient portal. So the work could actually be done much more seamlessly now than when we did it.
yeah, first good thing I've heard about Epic. No,
Well, I don't work for them, and I don't necessarily say everything's wonderful, but
No,
they have improved their patient-reported outcome reporting capability.
that's
well,
great.
I think they've improved in a lot of ways. Dave is right that, you know, in many ways when we did this, you know, Epic and frankly most electronic medical record systems were focused primarily on billing. You know, they were really all about getting the coding right, and the clinicians and the patients were sort of a secondary issue. But I think things have really turned, and as people have realized how these records can be used to really advance care, there's been a lot of pressure on companies like Epic to really improve the system so that we can do more with them. And it's a step beyond even just making sure everybody is up to date on vaccines or making sure people have had all their screening tests. It really gets into the visit, and more we're seeing them add stuff, and you can really personalize it a lot more that allows you to use the record to really help with management in a way that never was the case and wasn't when we started this, for sure.
That's great. So the punchline, what did you find?
Well, first I should emphasize this is a pilot study. It's not a huge study, and we don't want to we don't want to get ahead of our skis on our findings. However, we did find a lot of interesting things. I already mentioned that baseline finding that whereas pain and function were, the two main things that patients wanted to focus on in terms of their target, accounting for more than 2/3 of patients, closer to almost 80%. Fatigue was also quite high on the list, with 16% of patients. We did also pay close attention to the extent to which the information from the patient had an influence on change in practice, change at a given visit. And of course, with those patients with the CDAI below 10, there often weren't changes. And when there were changes, a couple of times, it did relate to the information that came from patients. However, when CDAI was above 10, there were, of course, more changes in management that were done. And a fair percentage, I'm sorry, I don't remember the exact number, but a fair percentage of the time, the clinicians and the patients felt that change was influenced by their participation in the study and the discussion that occurred. Not all the time. Sometimes the decision was more based on a clinical metric outside of the patient report. But I would say it's fair to say that we showed that when you do engage patients in the process of putting information together to make decisions about treatment and targets of treatment, that sometimes what they have to say does enter into that decision. Other times there are other factors at play, of course, because it's not always a straightforward process making these clinical decisions. I'd invite Eric, if you would, Eric, to just kind of spin off on that basic idea.
Absolutely. I mean, I think that was the most interesting thing for me. As Dave said, it was about a quarter of the patients who didn't do what the sort of treat to target guidelines would have suggested. They either didn't escalate therapy when it should have been appropriate by their clinical outcome, or change therapies when maybe it didn't look like they needed to. And when we asked the clinicians, did the measurement of some of these PROMIS measures enter into that, they said yes, in about a quarter of the cases. And to me, I don't know that there was any individual finding that was helpful, but it spoke to the idea that there are specific things that you can get at when you talk to patients that you're not capturing in something like the CDAI, which just is swollen joints, tender joints, and a sort of a global metric of disease activity. And so it spoke to the importance of that. Hindsight is always challenging. And so in retrospect, we wish we had drilled down into that more to try to understand what about the PROMIS measures, made people change their minds or not do what otherwise they might have done. And I don't think we got as granular information as we would have liked to have, just because of the way we asked the question. But that's something I think we can do going forward. One of the things it's prompted us to do is we've worked with some other folks within Dave and George's group to develop a dashboard that's integrated into Epic that captures some of those things ahead of the visit and gives the patients a chance to enter them ahead of time. And that's now available as soon as we open up the visit in clinic. And so we can see where they're at and see their answers to some of these questions. And I think we're the next step is to take that forward and see how much that kind of helps improve our ability to manage these folks with time. Importantly, when we did that, when we did the dashboard, we brought patients into that. We got patients involved in the development of that to make sure that their needs were there. And one of the things we learned very clearly from them is you can ask sort of formatted questions, but they really like to have some open-ended place to enter things that concern them before the visit. And, when you sit down in the room and that pops up right in front of you in Epic, it's really helpful because it tells you what's important to them at that time, and you can tailor what you're doing around that.
Yeah, I think that's important. Go ahead. Sorry.
I think the question on the dashboard is something like, what do you want to be sure gets talked about today?
Yeah, exactly.
Chance to say this. If we don't cover anything else, let's be sure to cover this. One other thing I just want to mention is as a result, if you will, and again, this is something that won't be an aha moment for the rheumatologists who are listening in, but it is important, and I'll try to say why. And that is that when patients had a major CDAI change, and we define that as 5 points in this project, they also had benefits on pain, physical function, fatigue. So they showed benefits in their function and symptoms that reflected the fact that they were getting improvement on their disease marker, the CDAI. And it was most dramatic for pain. However, it wasn't one-to-one. So there are patients that did not have CDAI change who did have functional change, and vice versa. There were patients with CDAI improvement and worsening that did not get the functional benefit. And that's, of course, in the end, what people really experience and base their quality of life by. So it's added information. They do overlap enough to show validity, but not so much so that you don't need the information to get a good look at how the patient's doing.
Yeah, I think that's important that we realize we focus. It's easier to focus on joint counts, physical function as we measure it. It's faster, it's easier, it's what we're used to. And not surprised that we miss maybe 25% of the importance or 25% of the patients, what's important to them. I like, and that idea is great of what's important to, what do you want to talk about today, if nothing else? And it pops up in front of you. What a great idea. Really.
I can add a comment as well, and this relates back to the original aims of the study. We also need to report that, the patients, remarked in post-study visits that they were very much satisfied with the care and the treatment they received. Those scores increased over time. Interestingly, those scores increased for overall RA treatment, but when we look at the individual subscales of treatment satisfaction, we didn't see changes there. And the way that we understood that is sort of those scores were all already pretty elevated when we started the study. So we didn't expect to see a huge change there, and we didn't, but overall, patients seemed really satisfied with this approach that Eric was able to implement in the clinic with other rheumatologists.
Well, that's because it was Eric's clinic. How could you expect better care than you get? So I think we got at it a little bit here, the implications. So where's this going to go at the conclusions? How is this going to change? Has it changed daily care? Should it change daily care? Or are we too early?
Well, I think it's led to this dashboard, which I think is very helpful. And, some of the next steps is to kind of look a little bit more deeply at some of those questions. More broadly, I think the place where it'll change care is more individualized care. We talk so much these days about personalized medicine, but everybody many people interpret personalized medicine as picking the right drug for the right patient. But it's way more than that, and it's really much more individualized. So it's not just the right treatment, but also how you apply that treatment and how you make decisions on when to change that treatment. And so much of that is individual. And so we're really next steps are working to try to understand that a little bit better so that in the long run, people can both be improved and happier with their care and feel like they've gotten what they need out of their visits.
I think what I would add to that is
like what we have. Go ahead.
Oh, I'm sorry, Earl. I
go ahead,
was going to say what I would add to that, really on a different track, is that 8 to 10 years ago, in order to do something like this, you really, we had to have a research grant and launch it as a research project. Right. Now, with the improvements in Epic that we talked about, with the idea that you can go into your most electronic health record portals and come up with an administration of questions that you can routinely ask with patients and create a single site specific dashboard of your choosing, that you can actually pull this off in clinical practice now without needing to make it a research project, and start to incorporate patient reported information into your practice.
That's a great point. It's a great point.
Yeah, excellent. I think that's really encouraging and really pushes for this ability to integrate our records and use it correctly. As Eric said, it's one thing to say how your vaccinations, which is important, don't get me wrong, but it's another thing to say what's important to you and how can we work on it.
Exactly.
And have it in front of you, not hidden somewhere else. So I think that's fantastic. And so having said that you don't need research studies, where's this going to lead to in research?
Engagement. Our big challenge now is engaging patients and clinicians. You can set this whole thing up, but it's not a field of dreams.
Right.
You know, I can't speak right now. Eric can speak to the rheumatology practice, but I'm working in other clinical areas, and we get around 25% patient engagement if we just put it out there. And you know, we need to get to 90% patient engagement, and so it's a big lift. And then there's the best way to get the patients engaged is to get clinicians engaged. Eric, you know, went through a conversion whenever 15 years ago, but you know, not every rheumatologist sees this as the light. And you know, so I think engagement is where that's where we've turned our focus. We have the tools, but now we got to figure out how to get people engaged in using them.
That's fantastic. That's great. Anything we missed, do you think?
No, I think, I mean, Dave's right. And I think one of the things that this hopefully will achieve is I think the clinicians will become engaged when they see how it actually helps them practice. One of the struggles we've had, particularly in the last 3 years over the pandemic, is this huge explosion of these messages back and forth between patients and physicians. And the electronic medical record makes that possible. So patients can send you messages all the time. And it's a lot of work for physicians trying to handle all that. And so if we can figure out a way to do it at the visit so that there's not all that stuff trailing on afterwards, I think it's going to make lives easier for physicians. And I think they're going to see the value in that, to try to capture all those questions when you're sitting with the patient, so you can do that in real time as opposed to having them drift in over time between visits. There are always going to be questions that come up in between, but the more you can address the things that people care about at the visit, the less they're going to feel that they need to do those things afterwards, or they need to come back at you afterwards and say, well, what about this? What about this? And I think we'll all be both happier and more successful at treating patients if we can do that.
Yeah, I agree. Great. Wow. So that's great. I want to thank you. Unless anything else to add, I don't want to cut anybody short. This is a great discussion. And I think it opens the door for we can actually use technology better. And that's really encouraging, you know. And I think it's going to get more and more. And we were just discussing at our meeting about maybe that you could use all these like ChatGPT to design things for your patient. And leave it to people like David and George to think about that, stuff like that, of how we can customize this to the patient by using artificial intelligence. I have trouble using my own intelligence, let alone artificial intelligence. All right, so I want to thank you, the three of you, for taking the time to read the findings. A very interesting paper, and I hope provocative, and I hope changing practice. And I invite the viewers and listeners to read the complete manuscript. And I hope this intrigued you to do that. And the manuscript's called Integrating PROMIS Measures in a Treat to Target Approach to Standardize Patient-Centered Treatment of Rheumatoid Arthritis. Articles now available at the journal's website at jroom.org and will appear in the August print edition. And I want to thank my three guests as well as the audience for joining us, and hope you'll come back next month, when I speak to the author or authors of another paper of interest from the September 2023 edition of the journal. And if there are any comments or questions, please send them to Twitter at jroom or by email to manuscripts@jroom.com. Thank you.